Let's discuss an unexpected diagnosis. Sometimes a disease can be completely unanticipated and may be missed simply because it's not on our diagnostic radar. Today, we'll review one such case. The patient is an 11-year-old boy who presented with enlargement of a level 1 cervical lymph node for 2 weeks. The initial clinical impression, quite reasonably, was infection, which is common in children. The patient was treated with antibiotics for 1 week, but there was no improvement, prompting a fine needle aspiration, or FNA. This image shows one of the smear slides. We see lymphocytes of varying sizes with admixed eosinophils, highlighted by red circles. Careful examination of the lymphocytes reveals no atypia. There are no large or atypical cells, and the lymphoid population appears polymorphous. Another smear fragment shows crush artifact, making detailed evaluation difficult. Although only a few intact cells are present, some nuclei appear enlarged and angulated, raising concern for atypical cells. On the cell block preparation, there is abundant blood and 2 small tissue fragments. In the first fragment, significant crush artifact obscures most cellular detail, but clusters of eosinophils are present. In the second fragment, again, crush artifact limits evaluation. Within a red circle, there are footprint cells suggestive of a granuloma, while in the black circles, enlarged nuclei are noted. Overall, the specimen shows lymphocytes, eosinophils, and rare enlarged nuclei with prominent crush artifact, making morphology non-diagnostic. Given the presence of eosinophils, the initial differential diagnosis included Hodgkin lymphoma. CD3 immunostain highlights T cells. CD20 immunostain highlights B cells. Flow cytometry shows no evidence of lymphoma. Additional immunostains and consultation with the hematoppathology team confirmed no evidence of lymphoma. Because of the possible granulomatous features, microbial stains were also performed but were negative. At this stage, the question became, what else could be causing this lymph node enlargement? Further immunohistochemical stains revealed that the crushed cells were diffusely positive for AE13, confirming epithelial differentiation. These cells are also positive for P40. Cytokeratin CK56 are also positive. This led to the diagnosis of metastatic squamous cell carcinoma, an unexpected finding in an 11-year-old boy. Given the biopsy site of level 1 lymph node, EBER in situ hybridization was performed, which was positive, supporting EBV-associated nasopharyngeal carcinoma, NPC. Despite limited tissue remaining after multiple rounds of workup, tumor cells were still identifiable. Final diagnosis is metastatic EBV-positive nasopharyngeal carcinoma. Follow-up imaging study showed a vague nasopharyngeal mass. Subsequent surgical resection of the nasopharyngeal mass showed an undifferentiated nasopharyngeal carcinoma. Nasopharyngeal carcinoma, NPC, is a squamous carcinoma arising from the nasopharyngeal mucosa. It is rare in most parts of the world, but shows higher incidence in southern China and in certain regions of Alaska and Canada. NPC is most common in older adults, ages 65 to 74, but has a smaller incidence peak between 15 to 24 years, meaning it can occur in children, though rarely. EBZ and high-risk HPV can be detected in some cases, and their presence is associated with a better prognosis. Therefore, routine testing for EBV and HPV is now recommended for all cases of NPC. In summary, we discussed a case of metastatic nasopharyngeal carcinoma in an 11-year-old boy. The specimen demonstrated significant crush artifact, making morphologic assessment challenging. In daily practice, various artifacts, such as crush, cautery, and drying artifacts, can compromise or even prevent accurate morphologic evaluation. We must always remain cautious and avoid assuming that areas obscured by artifact are benign.